Hello, this is Dr. Gardner, and I will be lecturing today on bipolar and schizophrenia. So bipolar disorder and schizophrenia are two significant mental health conditions that can manifest during childhood and adolescence. Both disorders are characterized by distinct symptoms, diagnosis criteria, and treatment approaches. Understanding these conditions is very important for early identification, accurate diagnosis, and effective interventions. The DSM-5 introduced the diagnosis of disruptive mood dysregulation disorder, which you guys learned about in a previous lecture, to address the chronic irritability that exists outside of the distinct mood episodes. And this diagnosis has become a diagnostic home for many children who previously would have been given the diagnosis of bipolar disorder. So while yes, it is gaining momentum and some practitioners are using bipolar for children, others prefer to use DM and DD. So what is bipolar disorder? Bipolar disorder is a mood disorder that's characterized by extreme mood swings, and they have these high highs or these low lows, and those high highs are mania, and it can be mania or hypomania, and I will explain the difference between the two. The lows is like a really, really low depression. In children and adolescents, the presence of bipolar disorder can be complex due to overlapping symptoms with other disorders like ADHD. Bipolar disorder, historically considered rare in children and adolescents, is starting to gain some momentum with some providers, and they are using the diagnosis. So bipolar 1 is mania and bipolar 2 is hypomania, and we will go over that. So let's talk a little bit about the neurobiology of bipolar disorder. So neuroimaging studies using MRI techniques have revealed structural brain differences in individuals with bipolar disorder compared to those without. The amygdala, which plays a key role in emotional processing and regulation, often shows increased volume or hyperactivity during manic episodes. It's the amygdala that plays a significant role in the dysregulation aspect of bipolar disorder. So that's probably really important, right? It's the amygdala that plays a significant role in the dysregulation aspect of bipolar disorder. The prefrontal cortex, structural abnormalities have been noted in the prefrontal cortex, which is, crucial for executive functioning, such as decision making and impulse control. Reduced prefrontal cortex volume or activity may contribute to impaired judgment and emotional dysregulation as seen in bipolar processes. Some studies indicate that reduced hippocampal volume among individuals with bipolar disorder, and this could affect like memory and learning. And research suggests that cerebellar abnormalities that may relate to mood regulation and motor control. So what about the neurotransmitters? The dysregulation of several neurotransmitters plays a role in bipolar disorder. So with dopamine, elevated levels of dopamine are often observed during manic episodes, while reduced levels may be present during depressive episodes. The dopaminergic system's hyperactivity is thought to contribute to the euphoric and energetic states that's characteristic of mania. Serotonin is another neurotransmitter implicated in mood regulation. Low serotonin levels are frequently associated with depressive episodes in the bipolar population. The relationship between serotonin and mood stability suggests that serotonergic dysfunction may play a role in the cycling of mood states. Now, let's talk about norepinephrine. This neurotransmitter is also believed to be involved in mood regulation. Increased norepinephrine activity has been linked to manic symptoms, while decreased activity may correlate with the depressive symptoms. Remember, we talked about that in the last lecture. And then there is glutamate. So there's more research coming about that highlights the glutamate. And that's an excitatory neurotransmitter. Abnormal glutamatergic signaling may contribute to mood instability and cognitive defects observed in affected individuals. So remember, you guys probably heard a lot about glutamate in psychopharm. So all of these neurotransmitters are important because you need to know their function when you're assessing your patient and getting a good history so you can determine which neurotransmitter you're going to be focusing on. Sorry about that, it went backwards. Let's see if we can get this going the right way. Okay, so the functional neuroimaging techniques like the MRI have provided insights into how brain activity differs during various mood states in bipolar disorder. So during the manic phases, increased activation has been observed in regions associated with reward processing, like the ventral striatum, alongside decreased activation in areas responsible for self-regulation, like the medial prefrontal cortex. So depressive episodes are often characterized by decreased activation within the reward-related circuits and increased activation within regions associated with negative emotional processing, like the amygdala. So with mood stabilization, treatments like lithium or anticonvulsants can lead to changes in brain activity patterns that promote mood stabilization by normalizing hyperactive circuits during mania or hypoactive circuits during depression. Do you need to know all that for the exam? Probably not. Is it good information to know as a Psych NP? Yeah, probably so. So what's the diagnostic criteria for bipolar 1? Well, they have to have a manic episode. A manic episode is a distinct period of abnormally elevated, expansive, or irritable mood lasting 1 week. So that duration is important. And for any duration if hospitalization is necessary, so it won't have to be a whole week. But it's usually about 7 days, and these people usually get into some type of trouble. So during this period, 3 or more of the following symptoms must be present. They have this inflated self-esteem, they're on top of the world, they are usually better than everybody, you can't touch them, I mean, they are just like out there. And they have a decreased need for sleep. So like they can sleep 2 or 3 hours a night. They're up and fully going all day. They're from this project to that project to this thing. They are all over the place. And they are more talkative than usual. So normally somebody's like, what in the world is going on with them? Because they don't even recognize the personality in this person when they're manic. They may have a flight of ideas. So of course they're from one thing to the next. Their thoughts are racing, they're easily distracted, they have increase in goal-directed activities, either socially, at work, sometimes they're sexually promiscuous, or they have some kind of psychomotor agitation. Let's try and move this down so you guys can see it. They're engaging in activities that hold a high potential for consequences, like they can go and spend all of their money online gambling because they're high. Oh, I'm going to win. I'm about to win this money, and they lose all their money. Or I had a young teen who said she was sexually promiscuous during her manic phase, and she slept with 3 guys in college she did not know. And that is not her normal personality. They may do drugs. They may, have a need for speed where they are speeding. Like, it's just really stuff that is out of the ordinary. They usually just can't keep still. So during a manic episode, a patient usually has increased energy. They sleep much less than usual, and they just can't keep still. They're usually more talkative, very easily distracted, can't get through any kind of projects or assignments that they're responsible for. Okay, so let's talk a little bit about bipolar 2 disorder. Bipolar 2 disorder involves at least one major depressive episode and at least one hypomanic episode, but not a full manic episode. And the criteria would be like this. A hypomanic episode lasts at least 4 consecutive days. It includes similar symptoms as those listed for mania, but it doesn't cause like a marked impairment. So these people don't end up in the hospital. They don't end up in jail. They're still able to function, but they know the difference in this mania that they're having. They usually enjoy it. They also have a major depressive episode, which is the same characteristics from the depression lecture. They cannot have had a manic episode, a full-blown manic episode like we talked about for bipolar 1. They have a hypomanic episode, so there is a difference. If they've ever had a manic episode, it is not bipolar 2, it's bipolar 1. They do have functional impairment. The depressive episodes must cause significant distress, but don't necessarily lead to functional impairment as seen in like a full-blown mania. The average onset is in the mid-20s. It most often begins with a depressive episode, so you won't know right away. These people don't know right away that they have bipolar 2. Oftentimes, they'll have several depressive episodes before they have a hypomanic episode, and you may not know if they've had a hypomanic episode without doing the appropriate assessment. They may have anxiety or substance use or an eating disorder that precedes the diagnosis. Again, they may have several major depressive episodes prior to their first hypomanic or recognized hypomanic episode. They could even have like a 10-year lag between illness and onset of diagnosis of bipolar. So it's highly recurrent, where 50% experience a new episode within the first year. 90% of patients who experience a single manic episode will go on to experience recurrent mood episodes. And that's probably important, right? So 90% of patients who experience a single manic episode will probably have more mood episodes. So let's kind of take a look at a case and see if you can pick out bipolar 1 versus bipolar 2. A 28-year-old patient reports 1 week of increased activity associated with an elevated mood, a decreased need for sleep, and inflated self-esteem. She does not object to her current state of, I'm getting more work done than ever before. A physical exam and lab work are unrevealing for any kind of medical cause of her symptoms. She had taken fluoxetine for a major depressive disorder, but self-discontinued that about 2 months ago because she felt that her mood was stable. which diagnosis best fits this clinical picture. Now, from what you've gotten already, I want you to pick out, is that bipolar 1 or bipolar 2? And you might have to go back and listen, and that's okay, but I want you to figure out, is that bipolar 1 or bipolar 2? So bipolar 2 has a major depressive episode involved. The criteria for a major depressive episode include 5 or more of the following symptoms during the same 2-week period. And this is just a review because you guys have had this already. Depressed mood most of the day, nearly every day. They have the anhedonia, where they have diminished interest or pleasure in all or almost all their activities. They may have significant weight loss when they're not dieting, or weight gain because you know that either they're eating their feelings or they're too stressed to eat. So they can have a decrease or increase in appetite. They may have insomnia or hypersomnia, psychomotor agitation, fatigue or loss of energy, feelings of worthlessness or excessive guilt, and they can't really concentrate. They have a diminished capacity to concentrate. And they also have recurrent thoughts of death. And so this is just a review because you guys have had this already. The episode cannot be attributed to physiologic effects of a substance like some kind of drug or medication or another medical condition. So what are some of the characteristics we look for? People with bipolar disorder have or can experience extreme mood swings. They may be overly euphoric or overexcited, and that's when they're manic. They might be extremely sad or hopeless when they're depressed. Sometimes a mood episode can include both of the symptoms, and that's what we call mixed states. So they're kind of going back and forth, or they have both of those, the euphoria and the depression. Extreme changes in energy, activity, sleep, and behavior are also characteristics of somebody with bipolar. So how do we diagnose? Well, we have the diagnostic criteria, but we also want to look at family history because a first-degree relative with a bipolar disorder is very common in those being diagnosed. Usually they have a first-degree relative that has it, or they have multiple relatives with psychiatric disorders. They may have a family history of multiple instances of suicide attempts, incarcerations, or drug and alcohol use. And a positive prognostic feature in bipolar disorder is the age at which the symptoms first begin. So their personal history when they come in, they usually have had multiple divorces, episode of depression, usually starting early. They've tried 3 antidepressants and none of them have worked, or they can't tolerate antidepressants because they cause mania. They may have legal or financial issues. They may have attempted suicide. So when we talk about suicide, women attempt suicide more often than men, but men use a more lethal method of suicide in bipolar disorder. It affects males and females pretty much equally.